Good morning, everyone. My name is TK Broderick. Welcome to today's webinar from Temple Health in Philadelphia. I'm today's moderator, and I'm also a point of contact for all providers outside of our system to access our advanced lung disease programs. As you know, Temple Health's lung transplant program has grown into one of the most active and innovative in the USA over the last 10 years. During the COVID-19 era, lung transplant may be a life-saving therapy for a segment of patients who have survived, but still present with persistent lung failure despite optimal therapy. Allow me to introduce today's presenters and Temple Health faculty, each who have prepared about a 10-minute talk to cover important topics in this area. First, we'll hear from Dr. Chirantan Mangukia, who's Associate Cardiovascular Surgeon at Temple University Hospital. Dr. Mangukia has expertise in adult cardiac surgery, VAD, ECMO, and of course, heart and lung transplant. And today we'll share surgical advances in lung transplant. We're also joined by Dr. John Galley, who's Assistant Professor in the Department of Thoracic Medicine and Surgery. He's a transplant pulmonologist at the Temple Lung Center and one of our researchers, and also has clinical interests in interstitial lung disease, to speak today about timing of referral and patient selection for lung transplant, including COVID-19. We also this morning have Dr. Aaron Mishkin, who's Assistant Professor in the Department of Medicine at Lewis Katz School of Medicine here at Temple. He is board certified in both internal medicine and infectious disease, which, as you know, is one of 2020's top specialties, and also has a special focus in prevention and management of infection in immunocompromised and transplant patients. Also, Dr. Stacy Brand, who's Assistant Professor of Surgery, Lewis Katz School of Medicine, one of our thoracic transplant surgeons, and he'll share today also advances in this surgical category. And we're also joined by Dr. Nora Hissa Shigemura, who's Professor of Surgery at Lewis Katz School of Medicine at Temple. Dr. Shigemura is our Surgical Director for Lung Transplantation, as well as Surgical Director for Lung Failure, and has published in this last year during COVID-19 on lung transplant in the COVID-19 era. So to kick us off, Dr. Mangukia, if you wouldn't mind putting up your talk and we'll get started. And I have to say, it's not a bad starting five. I might not put you up against the Sixers, but you all are certainly champions to the patients you serve. Look forward to hearing from you.
Sure. Thank you very much for the kind introduction. Thank you very much, everyone, for joining us. I'm going to present a glimpse of our program, how our program looks like, how it developed, and what we are doing special. First slide shows how our program was developed. In 2011, we got recertification from UNOS, and we slowly started our heart-lung transplant program, and you can see the numbers went up gradually and steadily. And I'm glad to say that we are one of the busiest lung transplant program in the country. Last year, we did 135 lung transplant. Along with the lung transplant, our heart transplant volume also picked up in last couple of years. Last year, we did 25 heart transplants. And naturally, along with that heart, we also had a good uptick in heart-lung transplant as well. Looking at the COVID-19 in last year, we had a pretty decent dip in the month of April and May. We didn't operate at all at the time of first wave. And then as the guidelines become more clear, testing become more widespread, we cautiously started accepting the donors. And I'm glad to say that we are back on track. Despite of severe pandemic, I'm happy to tell all of you guys that we didn't have any donor-derived COVID-19 infection. Thanks to Dr. Mishkin for the excellent guidance and help in donor selection. Last year, we got approved for Transmedic organ care system. We have been using it in selective cases. This organ care system has expanded our donor selection. Some of the donors are far away, some of them are DCD, and we do not hesitate to use this system for our sickest recipient who deserve lung quickest possible. Also, with a recent change in organ procurement organization policies, we are going to see a good uptick in Transmedic OCS because they started having infrastructure at the donor hospital and their local OPO site to provide us the Transmedics device and help us with the transport. We have done so far 5 Transmedics cases, and all of them went really well. In last few years, we following the scientific literature very closely, we have been modifying our practice. As you all know, that off-pump lung transplant has the best outcome, followed by those cases who will require intraoperative ECMO support and followed by cardiopulmonary bypass. Cardiopulmonary bypass not only increases the blood loss, increases the inflammation, and also increases the chances of PGD. So in last 3 years, we have been slowly moving our focus towards ECMO as a mechanical circulatory support intraoperatively. The left-sided pie chart shows the numbers from 2012 to 2017, and right-sided pie chart is showing from 2017 onwards. You can see that ECMO numbers have increased significantly. And that has translated in lesser primary graft dysfunction, shorter hospital stay, and less blood transfusion. Our patient care model involves a 3-pronged approach. Of course, patient and the family are heavily involved in all kinds of decision making. We really want to make sure it's since it's a very prolonged, tedious, and emotionally exhausting procedure, we really want to make sure that patients and family get enough psychological support. They have all the information about transplant going forward, pre-operative and post-operative course. Also, we involved our referring physician, our primary physician, very heavily in decision making. We also have a very abundant communication strategy along to build the interpersonal relationship with the referring physician. Our referral practice principles, as I mentioned, we acknowledge that referring physician owns the patient. A referring physician obviously sees the patient multiple times over the period of many, many years, and they have a special relationship. We are kind of a special skills provider. Of course, you have more attachment to the patients. We also involve you in the decision making. We make sure that you are in communication loop every time, and we also are looking forward to have mutual educational connections. As a referring physician, you know a lot more things than better than us that could be useful to our pulmonary fellows and surgical trainees. It would be really nice if some of you can come to our hospital, participate with seminars and webinars. It will be mutually beneficial. Thank you.
Thank you, Dr. Mangukia. And we'll move right into the next slide with Dr. Galley. And for everyone's information, Feel free to type questions into the Q&A box via Zoom webinar. We'll answer those at the end. You can also utilize the raise hand feature to voice a live question at the end of the program.
Thank you, TK. And thank you, Dr. Mangukia, for that introduction to transplant at our program. Today, I'm going to be talking a little bit about timing of referrals for the different categories of chronic lung disease for lung transplantation. And I'm also going to touch briefly on timing of referrals and consideration for transplant evaluation in the COVID-19 era. So to start, general candidacy considerations for lung transplantation. In general, these are patients that all have chronic end-stage lung disease who have exhausted all non-transplant medical options. Typically, we are seeking patients where we believe there is a favorable risk-benefit ratio with proceeding with this type of major surgery. So these are patients that have a high risk of death from their chronic lung disease within 2 years if lung transplant is not performed, and also those that we think have a high probability of survival, both 90 days after transplant as well as 5 years from a general medical standpoint. Briefly, I'd like to review some of these absolute contraindications to transplant, which may guide your decision to refer for transplant or not. One contraindication is recent malignancy within the past 2 years, and this would include all solid organ malignancies like breast cancer, lung cancer, colon cancer. The exception to this would be localized non-melanoma skin cancers, which if they are treated, do not prohibit the transplant process. Other major organ dysfunctions such as chronic kidney disease, heart disease, etc. Those with uncorrected atherosclerosis or coronary artery disease is considered a contraindication. In our program, for people with significant coronary artery disease, we will consider them for a combined CABG and lung transplant on a case-by-case basis. And I think our surgeons can comment a little bit more on that later in this discussion today. The only active bacterial infection that would be an absolute contraindication to transplant would be active tuberculosis. Other things to consider, BMI cutoffs, typically those with morbid obesity with a BMI greater than 35 would be considered a contraindication to transplant. Those without an adequate social support system or those with a documented history of non-adherence to medical therapy, and also those with active substance abuse within the past 6 months. I'm going to briefly review referral guidelines for the main categories of chronic lung disease that are considered for lung transplant. And this is based on the most recent international guidelines from the International Society of Heart and Lung Transplant from 2015. In terms of interstitial lung disease and pulmonary fibrosis, these are the guidelines for when to consider referring for lung transplant for those individuals that are interested in this intervention. And this may surprise you a little bit that it's a little earlier than I think we sometimes consider referring these people. One criteria would be any patients with either histopathologic or radiologic evidence of honeycombing, UIP pattern on CAT scan, or pathology, or also fibrotic NSIP. And the reason for this is that these are typically the patients with ILD that have the worst short-term prognosis and may progress despite best medical therapy that's available. Other criteria, patients with any supplemental oxygen requirement, not just at rest, but also if only with physical activity. Those with forced vital capacity less than 80% or DLCO less than 40, and also those with primarily inflammatory ILDs who have failed first-line medical therapy and have still progressed. In terms of when we consider listing for transplant in this category, we consider that for those who have significant declines in their pulmonary function tests over a 6-month period. Primarily, we use the forced vital capacity decline of greater than 10% in that time period. Also, patients with evidence of pulmonary hypertension on their transplant evaluation testing, and those that have acute exacerbations of ILD, secondary spontaneous pneumothoraces, or hospitalizations for rapid decline in their respiratory status. All of these criteria which would suggest a poorer short-term prognosis. With respect to COPD, typically you should consider referral for transplant for those with a higher Bode index, anywhere from 5 or above. Those with very severe airflow obstruction with an FEV1 less than 25% predicted. Patients that still have significant respiratory symptoms despite aggressive medical therapy, including pulmonary rehab, aggressive bronchodilator therapy, and supplemental oxygen. And also those that have really exhausted all other non-transplant advanced therapy options for COPD, which, in the current era would include bronchoscopic lung volume reduction, as well as surgical LVRS. In terms of arterial blood gases, also consider transplant for those with chronic respiratory acidosis with a PCO2 greater than 50, which has been associated with a poor short-term survival. In terms of when we consider listing these patients for transplant, one criteria is the Bode index, if it's greater than or equal to 7, which has been associated with, about an 18% 4-year survival, which would suggest a potential survival benefit if they were to get transplanted at that course in their disease. Also, those individuals with severely reduced FEV1s less than 20% despite aggressive medical therapy, those who have severe respiratory exacerbations requiring hospitalization and are associated with hypercapnic respiratory failure. Studies have shown that these people have up to a 50% 2-year mortality rate. So certainly they should be considered for transplant. Those with significant pulmonary hypertension as a sequela of their chronic lung disease, and also patients that continue to frequently exacerbate despite aggressive medical therapy. They also have a poor prognosis than patients with stable severe COPD. So pulmonary vascular disease and pulmonary hypertension, these are the criteria for considering referral for transplant. Patients that have NYHA class 3 or 4 severe symptoms despite aggressive pulmonary vasodilator therapy, patients that are on any form of parenteral targeted PAH therapy, and also patients with PAH from PVOD or pulmonary veno-occlusive disease or pulmonary capillary hemangiomatosis, which tend to be types of pulmonary hypertension that also have a much poorer short-term prognosis. With regards to cystic fibrosis, which is the last big class of chronic lung diseases that are often explored for lung transplant, typical criteria include an FEV1 of less than 30% predicted. Again, patients with pulmonary hypertension as a sequela of their chronic lung disease, and also patients that have clinical decline with frequent respiratory exacerbations, which may include things like bronchiectasis exacerbations with worsening development of multi-drug resistant organisms in their respiratory tract, development of secondary spontaneous pneumothoraces, or also patients with hemoptysis requiring embolization or other interventions to control bleeding. I do want to touch briefly on timing of referral in COVID-19 patients for lung transplant. Certainly we all know from experience during this pandemic, there is a significant subsection of people with ARDS associated with COVID-19 infection who do not respond to aggressive medical therapy. These are typically patients that are either intubated on VV ECMO, or maybe not, maybe they're just stuck on high flow nasal cannula with high FiO2 settings. And, sometimes these people can be stuck in an ICU for many, many weeks, even after they've completed their COVID therapies, and they no longer have signs of active viral infection. So the early experiences in the United States, as well as in other countries, have recently been published, and this group has come up with general guidelines that they are suggesting of when to refer for lung transplant. And I would say this has been in line with our practices here at Temple as well. One criteria would be being at least 4 weeks removed from the onset of your COVID-19 symptoms with subsequent negative COVID PCR testing. This would ensure that you're no longer infectious and that you would be able to handle aggressive immunosuppression and induction therapy at the time of transplant. The reason for an extended time period of being over 4 weeks, I think Dr. Mishkin could maybe touch on this a little more, but there is a concern for prolonged viral shedding, especially in patients that receive some of these strong immunosuppressives for COVID, such as tocilizumab or high-dose extended corticosteroids. Other things would be patients that have evidence of advanced and irreversible lung disease, such as development of post-COVID pulmonary fibrosis on serial imaging, and those that really haven't improved despite at least 4 weeks of supportive care and aggressive medical therapy. And other criteria would really be similar to patient candidate criteria that we use for all the different groups of chronic lung diseases that we discussed. So particularly, the age cutoff that has been proposed for COVID by this group is less than 65, which I think is not unreasonable, especially since many of these patients have prolonged hospitalizations, physical deconditioning, and often critical illness polymyoneuropathy, and also the absence of any other major organ dysfunction. Thank you.
All right. Good morning, everyone. Thanks to the previous speakers, and thanks for inviting me for this talk. I'm Aaron Mishkin. I'm one of the infectious disease docs here at Temple. I'm also the director of transplant infectious diseases. Okay. So today I'll be touching upon some of the topics that Dr. Ghali mentioned, as well as some additional topics with regards to vaccination and briefly on therapeutics. I want to start with vaccination because I think that this is important information to get out into the public and to get out into our thoracic providers, because it's so important, and I think it can be the cornerstone of our approach to COVID-19. I think you've all been amazed and impressed, SFI, with the pace of vaccine development and also the efficacy data in this particular vaccine. To date, I looked just a couple days ago, 1.9 billion doses had been administered worldwide, with 285 million of those in the United States. Just, it blows my mind every time I see those numbers, and I'm so happy that we were able to develop this vaccine so quickly. And we have really great safety and immunogenicity data in individuals who are healthy and who are immunocompetent. However, there's some concern in transplant recipients and patients who are on immunosuppression as to what's their vaccine response, what's their level of protection like, and we're starting to slowly unravel some of the answers to those questions. It's so challenging in transplant recipients to measure their kind of net state of immunosuppression. It's easy enough for us to measure tacrolimus levels or sirolimus levels, but to actually get a sense of what their immune system is doing, unfortunately, we don't have great measures of that. Likewise, we don't have great measures of is a vaccine protective? We can measure, certainly we can measure antibody levels, but it's difficult to assess if a certain antibody level, set at a particular threshold, really corresponds with a level of protection. Transplant societies, including the International Society for Heart and Lung Transplantation, the American Society of Transplantation, as well as several pediatric transplant groups and other adult transplant groups, have all kind of gotten together and formulated a joint statement, really unequivocally recommending vaccination in transplant candidates and recipients. And we'll talk a little bit more details about that. However, there's been some published data, which we'll go over, that shows that there is a diminished response to vaccines in transplant recipients. And that's causing a lot of anxiety amongst the transplant population, as well as different transplant providers. So I'm sure some of you are familiar with some recently published data. A group from Johns Hopkins, led by Dr. Boyarsky, was tabulating and collecting blood samples from individuals who had received the mRNA vaccines. They recently published this data in JAMA, and it showed when you measure specifically antibody levels 28 days after the second dose, that only 54% of individuals who were transplant recipients had measurable antibodies. So that was very concerning, because we know that these vaccines are so effective in immunocompetent patients, but we really want that data. We want this to be the golden ticket so that our transplant recipients can return to a normal life. However, there's a big caveat with that. Like I mentioned earlier, antibody levels are just really one small piece of the puzzle with regards to our immune system and with regards to our response when we're challenged for an infection. So another group recently looked at not just the antibody cutoffs, but also T-cell responses. So on this first figure, you can see that in individuals who are lung transplant recipients and were vaccinated, in this particular study of the 21, none of them actually produced measurable antibodies. These are patients who had acquired COVID and recovered, and a significant number of them actually developed measurable antibodies. And then this is a comparison to healthy individuals who are not transplant recipients who had received the vaccine. So obviously this is concerning data, but it's also in line with the data from the Hopkins. It does show maybe in lung transplant recipients, there's a little bit of a worse response, but there is some encouraging data. So the next graph looks at our T cells, so specifically our CD4 and our CD8 T cells. And of the 12 individuals who received the vaccine and did not develop antibodies, 4 of them actually developed measurable T cell responses. So that was encouraging. So in individuals who didn't develop any antibodies, they still showed that their immune system was capable of recognizing, specifically the T cells of their immune system were capable of recognizing COVID and mounting some sort of immune response. So we do feel that the vaccine is offering a certain level of protection, and we're starting to see some data trickle in. It hasn't really been well published yet that the vaccine is preventing severe cases. It's preventing our patients from getting on ventilators. It's preventing our patients from ending up in the hospitals. That, coupled with some of the other therapeutics we'll talk about, it is really helpful, is encouraging, not just for our healthy patients, but also for our transplant recipients. So the International Society of Heart and Lung Transplantation did report these recommendations. So obviously the best time to vaccinate is before the start of immunosuppression, so pre-transplant. If individuals do receive a lung transplant or heart transplant, it's recommended to wait 1 to 3 months, with 3+ months if they've received a lymphodepleting regimen as part of their induction immunosuppression. Some of the data that's come in has shown that individuals who are on lower doses or off of mycophenolate have an improved vaccine response, but the current recommendation is not to reduce immunosuppression. We do not want to precipitate rejection, so immunosuppression should not be changed. And while there's some interest in looking to see if there's additional doses of the vaccine would be recommended, that's something that has not been recommended outside of the clinical trial. Because of the very variable serologic response, we do not recommend that at this time. And transplant recipients still need to be careful depending upon what's going on in their community. So I know that Dr. Ghali talked a little bit about this and also referenced this study, which is one of the bigger ones, but still with a relatively small number of patients. But we are seeing that patients are able to successfully undergo lung transplantation after recovering from COVID. And the outcomes from that particular group were actually pretty good. Of the 12 patients that were examined at several sites from Dr. Barrett, 100% had a 30-day survival in their carefully selected group. So just expanding a little bit upon some of the criteria that were in that paper, those individuals had to have had severe lung injury for greater than 28 days, markers of irreversibility, single organ disease, so they didn't have multi-organ failure, and have to have 2 negative PCR testing. And the preference is for 1 upper testing, which is what most of us are familiar with, either the nasopharyngeal swab, an anterior nair swab, or an oropharyngeal swab. And then because we know that the virus, the SARS-CoV-2, and similar to other respiratory viruses, they do tend to have prolonged residence or delayed residence in our lungs. And it's important that we get a lower respiratory specimen to see if there's still active viral replication or active viral shedding in the lungs. That is also now a recommendation from UNOS for donors. So donors who are being considered for lung transplantation are recommended to have a lower respiratory sample with negative PCR testing before they should be considered for lung transplantation. And then it has to meet all of the other center candidacy criteria like Dr. Ghali discussed earlier. Lastly, I just wanted to talk a little bit about some of the therapeutics that are available for COVID-19. So the monoclonal antibodies are impressive if they're given early. They really, we're seeing both in immunocompromised and immunocompetent patients who are at risk for severe disease progression, if they're identified as having an early diagnosis of COVID, if we can get them into a center and give them an early monoclonal antibody infusion, it's impressive in its ability to stop disease progression. The clinical trials really looked at healthy and immunocompetent patients, but we do have some data that was recently published specifically in transplant recipients, although not really pulmonary transplant recipients. At this point in time, the Regeneron cocktail appears to be more effective against some of the emerging variants. The Eli Lilly cocktail appears to have less active neutralizing activity against some of the emerging variants. So the Eli Lilly initial cocktail was actually taken off of the market, the canalivimab, but now there's a combination that still is effective in certain parts of the country. But with the emergence of some variants, there is concern that that particular product is going to be less effective going forward. So a group out of Westchester Medical Center in New York examined the response of the monoclonal antibodies to transplant recipients who had a positive COVID diagnosis. In their study, in their case series really, they looked at 17 kidney patients, a total of 25 total patients, 2 liver, 3 heart, and 2 combined heart kidney. And they received the Regeneron combination monoclonal antibody product over that time period. The data looks pretty impressive. Of those 25 patients, none of them required hospitalization. None of them required O2 initiation. So that looked great in terms of preventing disease progression. They went back and they compared it to a group of transplant recipients earlier in the pandemic from March to August of 2020, when we still were in the infancy of understanding COVID. And at that time, there are 59 transplant recipients, a significant percentage of them required hospitalization, an ICU stay, mechanical ventilation, and unfortunately passed away. Granted, this is not a true crossover or controlled study, and a lot has changed with regards to our management of COVID patients. I still think that preventing all of those patients from requiring hospitalization is impressive, and that's something that we would recommend if you have any patients who are at risk of progression to severe disease, or if you have any transplant recipients. This is obviously something that we have here at Temple, and we can sometimes take referrals for it. Okay. Thank you so much for the talk.
Good morning, everyone. And I trust you can hear me. Welcome, everyone. And thank you for being part of our expose on our experiences with lung transplantation, especially in the era of COVID. My role here, I'm an assistant professor of surgery. I'm the surgical director of cardiac surgery, perioperative patient management, and my expertise is in thoracic transplantation, lung and heart, mechanical circulatory support, ECMOs, and VADs. We'd like to give you a brief overview of one specialized component of our lung transplantation program, which is the management of patients with concomitant severe coronary artery disease who are referred with that diagnosis, or who have that diagnosed incidentally at the time of their workup for lung transplantation. Thank you. So, as we know, lung transplantation offers a survival benefit in well-chosen patients with advanced lung disease. It is limited by critical donor shortage, which has not changed over the years, and therefore innovative ways of trying to meet the supply-demand deficit have been devised, and my colleague Dr. Mango here discussed some of them, using lungs which were considered to be marginal, and resuscitating these lungs using various forms of preoperative therapy like ex vivo lung perfusion. Now, over the past several decades, great strides have been made in patient outcomes. The lung transplant volumes continue to increase, and this is in part due to several issues, namely improvements in patient selection, which is crucial, improvement in our patient perioperative management, and also improvements in immunosuppression. Now, the ISHLT data shows that from 2010 onwards, the 1 and 5 year survival of adult patients for lung transplantation is 85% and 59% respectively. Excellent outcomes have been achieved in selected patients with high-risk comorbidities who a few years ago would have considered to be absolute contraindications. Such comorbidities include advanced coronary artery disease, age over 65, and pre-existing sensitization with DSA antibodies. From our point of view, from our institutional point of view, from what we've learned along the years, we do not consider advanced coronary artery disease to be an absolute contraindication in itself to lung transplantation. As such, we continue to be one of the few centers in the US that perform lung transplantation with concomitant CABG. We have adapted as we have learned, and we continue to learn as we adapt. we have developed an institutional algorithm for the selection of patients who are known to have severe advanced coronary disease or in whom it is detected during the lung transplant workup. Essentially, once a patient is referred and the diagnosis of severe coronary artery disease is made in consultation with one of our interventional cardiologists, all the patient's clinical status and imaging is reviewed by 2 attending cardiac surgeons in addition to the interventional cardiologists. Then decisions are made. The tree shows that revascularization will be deemed to be indicated or not indicated. It's tricky because sometimes it's difficult to tease out symptomatology due to advanced lung disease as compared to symptomatology due to advanced coronary disease or symptomatology due to both. Nonetheless, if it is deemed that revascularization is indicated, then patients who are deemed to be unstable from the clinical status and unable to tolerate a delay for PCI, then we will consider them for concomitant lung transplant and CABG. Those who have acute cardiac symptoms and relatively stable lung disease, then we consider them for pre-transplant revascularization, either via PCI or CABG, depending on their anatomy. In those patients in whom it is initially a very high risk to do lung transplant because of CAD severity, we consider pre-lung transplant PCI with a bare metal stent if revascularization would render these patients ultimately transplantable lung transplant-wise. And of course, patients who have stable cardiorespiratory status, we offer them concomitant lung transplant and CABG or lung transplantation alone. So it's an algorithm we go through, and of course, it's individualized because patients' symptomology changes with time between the time they're listed and while they're on the waiting list. Our experience since January 2013, when we began our program of concomitant lung transplant and CABG, thus far we've done 51 cases. The slide on the part of the slide on the left shows you the age breakdown, predominantly males, 88%, mean age 66. The oldest we have done is a 76-year-old. The diagnosis is predominantly idiopathic pulmonary fibrosis, 78% of the patients. Next up is COPD, 16%. And the other diagnoses are particularly less common, 1% each for combined pulmonary fibrosis, emphysema, sarcoidosis, bronchiectasis. In this cohort of patients, our lung transplant with combined CABG volume has been varying, you see, from 2013, 2015, notably in the pandemic era, which as far as we knew or we recognized is late December 2019, early 2020. You would see that, interestingly, our lung transplant volume, specifically lung transplant plus CABG, did not take a dip. In fact, it increased. We did stop doing lung transplantation completely for about 2 months in early 2020, when the whole world was coming to grips with the COVID epidemic. And we made institutional changes, staff testing, patient testing, how we conduct the operation. And then once on an institutional level and at a multidisciplinary level, we were convinced that at least we had some degree of a handle of the situation. We then gently began our program again. But it has not affected the lung transplant plus CABG volume since the epidemic. Now, in terms of the total number of cases done, as mentioned, 51 thus far since 2013. The proportion of those who had single left lung transplants, predominantly the largest proportion of the 51 patients, 23 were single left lung transplants, 12 of them were single rights, and double lung transplants with 16 patients. And the proportion of those who had single CABGs was by far the highest, followed by double CABG, triple CABG, and quadruple CABG. In terms of the support that we use during the combined procedure, the majority of these cases were done off pump. My colleague, Dr. Mangokia, mentioned that in our institution, we do predominantly off pump lung transplant to start with, and we are able to achieve off pump combined lung transplant and CABG in the majority of patients. We use cardiopulmonary bypass next, then VA ECMO and VV ECMO. We do individualize, obviously, our approach to mechanical support, and we do whatever we think is safest for the patient at the time of presentation. Many patients who have established coronary artery disease, based on the testing, we may deem it not necessary to do a combined procedure unless perioperatively ischemic symptoms develop. All patients in that category, once they have a diagnosis of concomitant severe coronary disease, they are prepared always for the possibility of CABG at the time of undergoing lung transplantation. Everything is prepared for CABG. If they don't need it, then they don't need it. They can always have post-procedure PCI if deemed appropriate, and all of this would have been adjudged preoperatively. The surgical approaches. The three main ones we employ were median sternotomy, antero-axillary thoracotomy, which is our mainstay, and a clamshell approach, especially for heart lungs. We favor antero-axillary thoracotomies here at our institution for generally doing single lung transplants and even double lung transplants. And we recognize that that is very much an institutional variation, but at Temple University Hospital, that is our mainstay. For the patients who require combined CABG and lung transplantation, strategic decisions have to be made at the time of listing. And those decisions are based on, one, which grafts need to be done, left-sided versus right-sided. Two, which lung or lungs need to be transplanted. If double lung transplant is required plus CABG, then we tend to do median sternotomy. If left-sided grafts are required, namely if the patient is deemed suitable for left internal mammary artery to the LAD only, or left-sided grafts, probably a diagonal as well, then we tend to approach that via a left anterolateral thoracotomy, and we can dissect the mammary artery through the thoracotomy, do the bypass procedure, the CABG, and then through the same incision, proceed to a left lung transplant. Patients who require right-sided grafts and a right or left lung transplant, when we approach that via median sternotomy, we can institute cardiopulmonary bypass easily through the right chest via right thoracotomy, and we then proceed accordingly. So we make strategic decisions at the time of listing, and these are clearly stated on the patient's surgical operative note, so that there is no scrambling to make decisions when a patient comes in for lung transplant. This is a picture of a patient who required a left lung transplant and CABG ×1 Lima to LAD. The top left picture shows the left internal mammary artery anastomosed to the Lima via the thoracotomy, which is open. And then the top right picture shows the heart being displaced up onto the left to expose the hilum. Here, the lung has already been explanted in preparation for transplantation of the left lung transplant. And the chest X-ray beneath shows a postoperative imaging. And in this particular patient, the ischemic time was 172 minutes. Patient stayed in hospital 11 days. Our normal stay following lung transplant, as we advised patients before, generally speaking, is about 2 weeks, provided there are no major issues that develop. Since 2013, of the 51 patients of combined lung transplantation and CABG that we have done, we have lost 4 patients, which is 8%, within 1 year. 2 died from COVID pneumonia. 1 from multisystem organ failure, not related to COVID pneumonia, and 1 died from respiratory failure, non-COVID pneumonia related. We have continued to evaluate our outcomes based on our changing practices, and we have documented on various occasions and presented these nationally and internationally. And interestingly, we have found that patients less than 70 and patients over 70 as well-selected patients, do not suffer a survival deficit of combined lung transplantation and CABG compared to their cohorts who had lung transplantation alone. We've also presented our institutional algorithm for, as I described above, at the AATS and several other international forums, describing our institutional learning process. And we continue to evolve and continue to learn from others, and all, of course, towards the best management of our patients. So how do we conclude what we've been doing so far with our successful combined lung transplant and CABG program? Well, we have to admit that our approach continues and will require individualization. The choice of grafts to be done is based on clinical factors. It's also based on the coronary anatomy, what type of mechanical support is required, if any, off pump versus on pump, and if it's on pump, do we need cardiopulmonary bypass versus VA ECMO? What surgical approach should we do? A median stenotomy, clamshell, or a thoracotomy? Do we need single versus double lung transplant? And of course, you can imagine all of these are very individual decisions which are tailored to the patient. And we have to admit that while we continue to forge along, we know that long-term follow-up is required in a larger group of patients. And also we know that we should continue to learn from other centers who are doing the same combined procedure. Thank you very much for your time. And we do hope that we have at least explained to you our rationale behind doing combined CABG and lung transplant, and that advanced coronary artery disease in this cohort of patients should not be considered to be an absolute contraindication in and of itself to lung transplantation. Thank you.
Excellent. Thank you, Dr. Brand. And thank you to all the presenters for sharing important information this morning. We have a few minutes left for a question and answer session. I think it's appropriate for the presenters, if you're okay, to turn your cameras on. We have a number of questions that have come in that I'll pose to the group. The first one being, and Dr. Brand and Dr. Shigemura, feel free to answer this. What is the preference for single versus double lung transplant for patients post-COVID? And is there a preference on the approach that you described?
Dr. Shigemura, would you like to take that one?
Sure. So basically, it depends on the patient's sickness. The most important thing is that, how quickly, if they are indicated, they get transplanted. So that's the priorities. Single versus double, we have experienced both for the patients post-COVID, but regardless of irrespective of the surgical options, actually the patients are doing well post lung transplantation.
Thank you. And we saw different age criteria, especially in the lung transplant plus CABG category, the ILD category. What is the age limit for lung transplant at Temple?
I will say that we don't have a specific age limit for lung transplant at Temple. We have done octogenarians, and I think we individualize care. Of course, with advanced age, you can expect a greater comorbid burden, and therefore you're going to find a lower percentage of patients of advanced age who may be suitable lung transplant candidates because of a comorbid burden. But we individualize it, and we are well known in this region and nationally to be a center of referral for patients who are rejected at other centers, and they come to Temple to get their second life, and we thankfully get them through it relatively smoothly, albeit we do consider them clearly to be high-risk patients. So we don't have an absolute cutoff in age limit. As you know, there are some 70-year-olds who are healthier and more sprightly than some 40-year-olds. So it has to be individualized.
Thank you. Dr. Mishkin, are there any differences regarding immunosuppressive pharmacotherapy for the group of patients non-COVID compared to COVID post-transplant?
I think that targets for immunosuppression would be the same. I would be curious to see if Dr. Sugimura has other extra input or one of the other surgeons, but post-transplant, there would be the same targets for immunosuppression.
The next question that came in was from Dr. Robert Stifo, and he asks, how should we, the ICU physician, determine who out of all the critically ill patients should be referred for transplantation, and what expectations should they discuss with patients and their families?
Dr. Gali, would you like to start with that one?
Sure. So what I would say is we are always open and welcome to discuss these types of difficult cases with you. Our typical process for considering a hospital-to-hospital transfer for an expedited inpatient transplant evaluation would include an initial telephone consultation with one of the transplant pulmonologists. And then after that, if it does not appear that there's any absolute contraindication, we would have you guys fax over some records pertinent to their inpatient hospital stay. And then we would have our medical and surgical director review your case. And as a committee, we would help get you an answer as soon as possible, whether this type of transfer for evaluation is prudent. Certainly, I think it's important to manage the family's expectations, especially in critically ill patients on ventilators and or ECMO, that the probability of success for transplant in those situations is certainly much lower than in patients with chronic, stable end-stage lung disease who are outpatients. So I think we do have to manage expectations quite a bit.
Thank you. And that leads to the next question from Dr. Sharif El-Bayadi. And he asks, did the role of the referring practitioner change during COVID? And if it did it lead to closer working relationships and co-management? And what have we learned that might change the process and lead to improved outcome? Anyone want to field that?
I wonder if John is best aimed to answer that one in terms of the referring, as it's usually a pulmonary to pulmonary referral, pulmonologist to pulmonologist.
Yeah, I think, especially for patients with who have outpatient pulmonologists that have a longitudinal relationship with patients, I think you are our most valuable asset in understanding the patient's disease process, progression of disease, and also, how they are as patients, if you think they're kind of up to the challenge of going through lung transplant, and certainly the chronic disease model and close follow-up that's required afterwards. So certainly our goal that we're always working to improve upon is to continue to collaborate with you guys, not just before transplant, but also afterwards. Certainly after these patients get transplanted and they're beyond a year post-transplant, we do expect many of these individuals to transition back to their outpatient pulmonologists and assume a lot of care with you guys, and the follow-up visits with us start to decrease after that first year.
Thank you. And Dr. Mishkin, I think that you just maybe typed a question answer here, but I think that's good for the group as well. And Dr. Guzari asks, should we consider a COVID medication prophylaxis in the future in addition to CMV PPX or a broader antiviral PPX?
Sure. So I did type a response, but unfortunately we don't have medications that are really been proven to prophylax or even very effective antivirals for the treatment of COVID. So our best strategies at this time is to encourage vaccination, and then to continue to advise our transplant recipients to still take precautions, especially if there's cases of ongoing transmission in the community. And then if they were to acquire COVID, for them to get a very early referral to a center that can give them a monoclonal antibody infusion. And then likewise notify their pulmonary, their transplant pulmonary team, so that they can make any necessary changes to their immunosuppression.
Thank you. Dr. Salam Al-Ubaidi asks, does CKD, which I believe is chronic kidney disease, exclude a patient from transplant? And does that also apply to patients with coronary artery disease and interstitial lung disease?
With regards to CKD, I would say our program's relative contraindication or relative cutoff would be a GFR less than 50. However, in select patients, especially those that are younger and otherwise considered very robust, we will, on a case-by-case basis, sometimes consider GFRs less than 50.
One comment I would add is that in CKD in lung transplantation, that impact is very significant in regards to post-transplant outcomes, in regards to the patient's quality of life after transplant. So because of that reason, to optimize their outcomes, we need to be cautious of evaluating their kidney function before transplant, but shouldn't be, exclude the patient's windows or the options just because of that.
Great, thank you. And the last question that I have, and I believe that we're come to about the end of our program, is there a registry of outcomes for post-COVID patients receiving lung transplantation?
So is that the question, the registry
the last
as
question
a program?
that I received. That's the last question I received, as the doctor asked if there is any registry that's tracking these patients and the outcomes.
Yes, that's actually ongoing project. And in this project, actually, we are carefully watching two aspects. One is certainly the outcomes for the patients post-COVID and after lung transplant. The other important aspect is to see how the patients are doing after lung transplantation under this pandemic. They are more susceptible to COVID-19, as Dr. Misikin bring the cautions, or something. So at this moment, yes, they are more susceptible to COVID. So we are very cautious, but this may be changed and improved with vaccination or medications in the development.
Excellent. Well, I'll thank all of you for your participation this morning, as well as the attendees who joined us. You all definitely illustrate leadership in this category, and we're proud to have you here at Temple Health. For anyone that feels that they have a patient that could benefit from our team, you saw our contact information, and I hope that you have it moving forward. you can always reach out to us any way that you can, and we'll be here to help you and your patients. Thank you for joining us this morning, and we'll see you again soon.
Thank you very much, everyone, for joining.
Thank you.
Thank you.
Thank you.